Good morning, people. We are really excited to have a visiting speaker come to us from all the way from Halifax. Dr. Karthik Tennankore is a nephrologist. He's a professor of medicine at Dalhousie. He did his medical training at the University of Western Ontario and a 2-year clinical fellowship in home dialysis at UFT. At the same time, he also did a master's in Clinical Epidemiology from Harvard. Currently, he's, of course, in Dalhousie, where his main focus of study is in improving outcomes in dialysis patients, including home dialysis and transplant, with a focus on how frailty affects that. And he's also a current executive co-chair for the CNTN and the Research Network Committee, co-lead for the Accelerating Clinical Trials Consortium. Welcome, Karthik.
Thanks a lot, Swapnil. It's funny, Swapnil invited me to give this talk. Hey, how you doing? I'd say, 2 years ago, I think. And I promised him that, you know what, give me like a couple of years. I got some things cooking, I'll be able to present to you some new stuff. Turns out I didn't do anything for 2 years. This is the same talk I would have given you 2 years ago. I do have some disclosures. None of these are particularly relevant to what I'm going to be talking about today. Although I will say I'm starting to use a little bit more GPT just to sort of see what it does with some images and figures, but not so much new content, just trying to take data and turn it into more visually appealing ways. Sure. So big objectives today. I thought I'd chat with everybody about the definition and classification of frailty. It may be something that many of you are familiar with. It might also be something that many of you are not. Talk a little bit about how frailty impacts patients really going from chronic kidney disease all the way to transplant. Chat about one large study that's finished this year, and we're hoping to have our main results out either at the end of this year or next year. And then touch a little bit on what's probably an evolving area with not a lot of data, but thinking about how we can start to use frailty in decision-making. So here's my first ChatGPT image. I don't think this is a real person. It was just actually, it's pretty neat actually what you can do with these things. But so what is frailty? So this is probably the best definition that I've seen. It's a syndrome of low reserve and reduced ability to resist against stress due to a decline across multiple body systems that leaves a person vulnerable to poor health outcomes. And when we think about frailty, we often think about it comparatively across groups of people of a similar chronological age. But we do know that frailty can occur both in those who are young and those who are older. And there was a large consensus group that got together, over a decade ago and tried to come up with all of the statements that encompassed frailty. This group included geriatric medicine specialists and healthcare workers in the area of geriatric medicine. And they came up with 39 separate statements about frailty. A couple of them that kind of stood out to me. So it is multi-system. It can change. It's not the same thing as disability, and that's an important distinction to make. It does leave people vulnerable. And this one's a bit controversial, but there is a thought that it potentially can be reversed, although maybe not, convincingly. It's also important to know what it's not. So if you look up a definition in a dictionary, it's really not the condition of just being weak and delicate, the sort of increasing frailty of old age. I think that's perhaps an oversimplification. And it's not weakness in character or morals. And that seems like sort of an obvious thing. But when you look at perspectives of patients, and this is something we always have to think about, what do patients actually think? A lot of them view frailty as like the F word, and it has quite a negative connotation. And in this one qualitative study, when patients sort of heard this term frail, they were sort of immediately defensive, put off, probably because they were thinking about things that maybe was not the intention of the practitioners themselves. So pathophysiology, I promise you, I'm not very good at pathophysiology, so this is the only slide that you're going to see. Lots of things that underpin this construct of frailty. You start off with a vulnerable patient, so maybe they're chronologically older, lots of morbidity in our population, this idea of uremic toxins and everything that they can do, other adverse event risk, maybe genetic risk. That can lead to a number of things, and there's lots of sort of studies that are elucidating these mechanisms. So DNA damage, attrition of telomeres, which is perhaps not just specific to kidney disease, it's really in all aspects of aging, but maybe accelerated in kidney disease. Potentially changes in hormonal balance that might impact things like diet and appetite. Of course, every sort of end pathway might lead to inflammation. So things like cytokine elevation, perhaps those hormonal changes are leading to low dietary protein intake. Of course, this idea of cellular senescence really underpins a lot of aging in general, and then maybe changes in how skeletal muscles handle protein. And that might lead to this entity called sarcopenia, so this age-related muscle mass that I refuse to let happen to me as I get older and older, but a lot of people do experience. It also might lead to low levels of physical activity, maybe depressive moods. And then, not just through this pathway, but through a number of different pathways, things like cognitive dysfunction. And then ultimately, all of these different mechanisms might lead to frailty. And they may do them together, but they may do them separately as well. When we think about it being a sort of a multi-domained entity, you don't have to have every single domain. You might have none of the comorbidities, but all of the functional impairment. You might have, largely cognitive dysfunction or social isolation, but you may not have some of the other features. So the idea here is that there are a number of different things that underpin this syndrome. But this doesn't actually help us classify it. So how do we actually assess frailty? Well, by far the most common tool that exists to assess it is something called the Fried frailty phenotype. Think of this as like an on-off switch of frailty, where you're generally classified as either frail or not, and maybe an intermediate sort of pre-frail stage. And it's really the answer to 5 questions. So do you have slowness, which is done by looking at walking speed adjusted for things like height? Do you have weakness? That's evaluated using a dynamometer to look at grip strength. Do you have weight loss, which is usually based on a question and an evaluation of one's weight in the preceding year? Some questions around exhaustion. And then the last one is, do you have low levels of activity, which is also typically achieved with usually a more elaborate questionnaire. There's something called the Minnesota Leisure Questionnaire, which was in the original Fried. People have used other types of tools like the IPAC, for instance. And if you sort of have a deficiency in 3 or more of these 5 areas, you would be considered frail. So this is like the most common tool that's out there. There are a couple of others I'll just quickly highlight. One that I think has some value to where I am, because it was developed by Ken Rockwood, who's a geriatric medicine specialist at Dalhousie, and really has been a powerhouse in the area of frailty, is something called a Frailty Index. So think of the Frailty Index as not a singular tool, but an approach to collecting deficiencies in health across a number of different domains that you can apply to your population. So frailty indices usually should have at least 30 or more conditions across multiple domains. You can define your own frailty index for the population in front of you. Ideally, though, each of those variables in that index have to have certain characteristic properties. They have to be things that you can acquire, not just traits. Usually things that generally accumulate with older age. They can't saturate too early, so you can't have like kidney failure in a frailty index being developed in a kidney population, and they should be multi-domained. And your frailty index score is the ratio of deficits that you have over the total number of conditions in that index. And it's funny, if you look in the literature, there's tons and tons of these frailty indices, all using different variables, different characteristics, different approaches, but they all generally have this kind of gamma distribution with a bit of a sort of a right tail. And it kind of makes sense as you accumulate deficits. Usually you're going to get fewer and fewer people that have a lot of these higher proportion of deficits, largely because the idea is this is leaving you vulnerable for poor health outcomes, including death. So it's uncharacteristic to have a frailty index score much above like 0.75 or 0.8, because at that point, the deficit accumulation is thought to sort of overwhelm the system. And then on the other side, we have more clinician impression type evaluations of frailty. This is one I'm very familiar with, called the Clinical Frailty Scale. This is an ordinal scale, ranking individuals from sort of 1 to 8. 1 would be those who are amongst the fittest for their age category, very fit, motivated, exercise a lot, very mobile. Whereas those in category 8 are very severely frail, completely dependent, approaching end of life, maybe couldn't even recover from a minor illness. When you look at clinical frailty scales in dialysis populations, maybe thankfully I would say, but not unsurprisingly, it is uncommon to have individuals with a score of 8, tends to sort of sit around that 4 to 5 range. And then often there's this category 9, and category 9 actually is not on the ordinal scale, but these are individuals who are terminally ill, but who are otherwise not frail. So an example of that might be someone who, say, has a terminal malignancy, but hasn't really experienced that kind of sarcopenia of malignancy yet, but you know that their life expectancy might be shortened. So how many tools are there? I could probably spend the whole hour just talking about tools. This was a systematic review that was I was a part of, that was led by Stephanie Thompson. She looked at 105 different studies, and of the over 90 different frailty assessment tools in the literature, more than 20 had been used in CKD populations, with the FREED, the Clinical Frailty Scale, and the Frailty Index being the most common of the tools. But maybe a more important question is, okay, well, which one is better? What should I actually use if I want to start to evaluate this? My view is that they each have some benefits and maybe some disadvantages. So if we focus on the FREED, it's that on-off switch. You're frail or you're not. The data sources can be a bit cumbersome. The Minnesota Leisure Questionnaire, if anyone's ever seen it, probably takes like 20 minutes to complete in of itself. So people have tried to modify it to make it simpler, I should say. But I would say it's very easy to understand. It's like a switch. It's like pretty simple. I just don't know if it captures the biological entity of frailty. It seems odd to me that something that's so multiply determined, you're either in one group or the other. You would think there'd be more grades or levels of severity. That's where the frailty index might have some advantages. It is a score, it is graded, but maybe a little bit harder to interpret. If you walk around saying, what's your frailty index score? Mine's like 0.23. Mine's only 0.25. So, I mean, what does that really mean? It's hard to sort of understand that. The clinical frailty scale, simple to understand. It's an ordinal scale. It has categories with descriptors, but this one's based a lot on clinical judgment. And we assume that that clinical judgment is informed. It was generally designed for geriatric medicine specialists to capture it, who had a full knowledge of the patient and all of the various impairments in their domains of health. But it's been probably stretched a little bit to people just arbitrarily assigning numbers after kind of looking at a patient, which we generally want to try to avoid. But this is a study that's nearing completion. I'm part of a group called the Kidney Disease Aging Research Collaborative. If anyone's ever interested, it's a North American group focused on trying to look at how to use frailty and inform things that we do. And it's led by Mara McAdams DeMarco in the US. And kind of an extension of that previous systematic review. But the big standout here in the scoping review, we looked at all the various frailty tools that are out there, excluding the FREED, so focusing more on ones that were kind of beyond sort of physical fitness. And again, you can see, the clinical frailty scale, the FI, the Edmonton frailty scale, frail scale, these are all ones that are used. But the big standout to me is this reliability point. So you can see that we really haven't properly looked at validity and reliability with any of these tools in our population. Very few studies measure it, evaluate it when you look in the literature. And in that previous systematic review that I showed, if you were to apply sort of a grade rating on how well these properties of these tools have been looked at in our kidney disease population, not very good at all. So vast majority of things across validity, reliability, and responsiveness, it's either an unknown grade rating or, generally a low or very low. The best sort of grade rating is maybe moderate for construct validity. And I think that's largely probably more of a predictive validity rating where we know that frailty is associated with poor outcomes. The take-home point here is that there's a lot of work to really evaluate these tools properly in our population, something that hasn't been done despite the fact that they've been used so much. But I also view that they may be, to some extent, complementary tests. So if you recall that pathophysiology slide, I showed you there's a number of different determinants of frailty. Maybe each of these tools is just capturing a different aspect of this underlying syndrome. This was a study we did looking, and I'll talk a little bit about it later, at how common frailty is in patients who are waitlisted or being worked up for kidney transplant. And you can see, like, when these kind of overlapping circles of the three big ones, the clinical frailty scale, FREED, and frailty index, are looked at, there's just a small overlap where someone is frail by all three approaches. And this is just showing you what agreement is using different kind of iterations of the FREED, the frailty index, or clinical frailty scale. The big take-home message is that yes, this might be perhaps the most vulnerable patient population of the group, but each of these tools might be capturing something else that's of value. And so I think from this section, the big take home points, lots of different tools. I think agreement is a little bit limited and there's more work to be done around things like reliability and discrimination. But I would generally say that if you're going to try to approach measuring frailty in your population, my view is always more is better. But you have to consider things like burnout and resources, because as I mentioned, some of these tools might be cumbersome to collect if you don't have processes already in place. Okay, so that's kind of a little bit about what the tools are. How does frailty actually impact health outcomes? This image on the left, for me, it is a GPT-4 image, but on the right, it actually isn't. This is from a review that was done by Rashida Hall, who's another big frailty expert out of the US, really just kind of characterizing like how many different studies exist looking at various measures of frailty and different types of health outcomes, including mortality, healthcare use, and other ones as well. So I'm just going to touch on really a few studies across the different areas. Again, a whole talk on frailty and outcomes probably isn't of interest. I think we can all sort of generally understand that it's probably not associated with positive health outcomes, but I'll focus a little bit on mortality and just go through a couple of different studies. So first in CKD, and this is a Canadian study, a shout out to Nav, who developed the CanFit prospective multicenter cohort. This is a study of individuals with CKD, GFRs less than 30, and Nav and his team collected frailty measures in a prospective fashion in this population, and really were interested in how frailty associated with all-cause mortality, but also dialysis choice. So what was the ultimate dialysis destination of these patients? So in this cohort, they found that there was quite a variability of the prevalence of frailty depending on which tool was used. The Freed on the low end, that kind of on-off switch, some clinical impression tools sort of in that 30 to 40 range. Not unexpectedly, if you look at the panel on the upper right, frailty was in fact associated with mortality, irrespective of which approach was used. But I think what was kind of interesting, if you look on the bottom, is that the sort of clinician impression tools were associated with a higher odds of starting with in-center dialysis, whereas the more objective tool was not. And I think this is where we start to see a little bit about how our own sort of unconscious bias or even outconscious bias might actually impact things like dialysis choice. You look at someone, you say, hey, they look frail, I don't think home dialysis is for you. And ultimately they get directed to more of an in-center modality. So I suspect that's what we're seeing here. And I have some other studies to show you a little bit later that might sort of reiterate that point. What about dialysis? Lots of literature looking at frailty and the impact in a dialysis cohort. This was our first study that looked at the clinical frailty scale in Halifax. And I think it was the first actually that used the CFS in the literature in general in this population. So we, in this earlier cohort, looked at a little under 400 patients who started on chronic dialysis. We measured frailty using the CFS, and the way that we did it was the clinician who was starting the patient on dialysis that was coming up with the score and assigning that score to that patient. We did that with the hopes that they had the best awareness and understanding of who that patient is. Of course, some people started as an inpatient, and so there may have been a different practitioner that did it. Ultimately, about 26% of the population was frail based on categories of the scale. You can see it only went up to 7 because it was a little bit of an older iteration. And about 50% had scores of 4 or more. What was really surprising, this is about 1.5 years of follow-up. And in that follow-up time, if your score on a one-time measure using the clinical frailty scale at dialysis initiation was either 6 or 7, none of those patients actually ended up getting a transplant and follow-up. I'm not even sure how many of them got referred for transplant, but it had a pretty sort of potent association with the probability of transplant. And this is a little bit of an extension of that study where we looked at joint modeling of hospitalization and death, and not unexpectedly, high relative hazards for recurrent hospitalization using that threshold score of 4 or 6 or 7, and then very high association with mortality as well. And this is after multivariable adjustment. I will also add, two kind of interesting things. One was that comorbidity, and in this case, we used the Charlson Comorbidity Index, which has its own problems, but it did not modify the association between frailty and mortality, and neither did age. So using a binary sort of cut point of age, there was really no difference in association with mortality. What about the subcohort of patients that are on peritoneal dialysis? Well, not quite frailty, but in the PDOP study, for those that are familiar with it, I worked with Jeff, and we tried to sort of generate a functional status score using a similar approach to what they did in their dialysis cohort. And this score was really based on the need for helps with respect to IADLs and ADLs, and individuals in this large cohort were categorized as being severely impaired, meaning they really could not independently perform multiple different ADLs and IADLs, a low score, to those with scores of 13, which means they could kind of perform everything independently. What you can see is this sort of graded increase, obviously, and perhaps expectedly, in the proportion of individuals that had a lot of impairment in their ADLs and IADLs based on these age categories. And similar for those that had that kind of moderate impairment. So about 20% had some degree of impairment that was maybe more in that moderate to severe range. Again, you can see here a pretty strong association with mortality. So the more impairment in ADLs, IADLs that you had, the higher chance of dying. Once again, adjusted for all sort of medical comorbidities as well as demographics. But similar to what I kind of showed you before, there was this interesting signal where there was really no association between frailty and transfer to hemodialysis. One of the reasons this might have been, and it wasn't very clearly elucidated in this PDOP study, was a lot of the patients who are quite frail were dependent on a caregiver, and that caregiver would have been delivering their dialysis at home. And we do know that patients often prefer to sort of maintain their treatment at home and would much rather avoid a transition to hemodialysis, especially those that are older and perhaps not interested in that experience. We then looked at this specifically using a frailty measure in our home dialysis cohort. So this was over an 11-year period. We had about 180 patients, of whom 65 had a clinical frailty scale score done. And you can see that none of these patients actually had scores of 7 to 8, but about 36% of them kind of sat in that 4 to 6 range. Again, similar type of signal, and association with mortality. We were limited in our ability to adjust for a lot of things in this, but certainly there was a signal there. But there really wasn't any association with time to transfer to hemodialysis. And I think that reiterates the point I was making in the previous slide. So frailty associated with mortality in dialysis and home dialysis and advanced CKD. But that brings me to transplants. You would think that our transplant patients should be some of the most robust. Are we still seeing a similar type of signal there? So this is work done by Dr. McAdams DeMarco, looking at about 500 transplant recipients in the US over a 5-year period. One of the things that stands out, you can see, is the proportion of people that are frail, perhaps expectedly, is a little bit lower. I mean, generally, you're going to transplant individuals that are more robust, not in all cases, but we know that that's often the case. And over time, comparable, I would say, risk for mortality up to about 3 years, but then a big fall off at that 5-year mark. So about 77.5 versus 94.3, comparing those who are frail, meeting those criteria, versus those who are not. And sort of said differently, after a multivariable adjustment, those who are frail were about twice as likely to die after transplantation. In the transplant population, studies looking at readmission. So this is the same cohort, but a different outcome. And they looked at the risk of early readmission, which is within 30 days after being discharged from your hospitalization for transplant. Again, you can see a higher risk of early readmission for those who are frail. But I think what's kind of interesting, again, is that lack of sort of age effect modification. The proportion of patients who are readmitted was similar in those who were less than or more than 65. And for transplant, again, we can go on and on. In the short term, higher risk of depressive symptoms, longer hospital stay, delayed graft function. In the short and medium term, Frailty is associated with intolerance of immunosuppressive medications, so MMF withdrawal, and potentially cognitive difficulties after transplant as well. So does all this really matter? Like, yes, I can bore you to death with like 1,000 studies of mortality and different health outcomes. And the first thing I'll often hear is it's just the same thing as getting old. But I think we have to appreciate in our population, chronological age, that biological age, perhaps are not synonymous. Again, I often hear, isn't this just another comorbidity index? You're just putting a bunch of health conditions in a scale and kind of measuring them out. You can have somebody who is quite frail and they have no other medical comorbidities. And the idea here is not to just capture comorbidity, but sort of those multi-dimensional aspects that ultimately lead to the decline in patients. And then the last thing I very often hear is like, I don't need a tool. I can look at someone, I'm like the best. I can tell you what's going to happen to them. I think we can all probably agree that's not the case. And there was a hemodialysis patient study that was done where they looked at the gestalt versus like objective frailty. And really the agreement with the gestalt was very low. So I don't think we're that strong at sort of identifying individuals who are frail just based on our clinician impression. So the big take-home points from this section, I think, it's pretty clear that frailty impacts health outcomes with or without other health conditions and irrespective of age. And if I were to kind of make a little bit of like a roadmap, it's surprisingly similar. So, in your CKD population, you have a group of people who are frail that are at about a 1.5 to maybe 2-fold or a bit higher risk of death. Of the people that then move on to hemodialysis, it's very similar. Peritoneal dialysis, very similar. Then you have, a robust population that gets transplanted. Of those who are frail, again, that higher risk of death. But is there a population that's missing that we maybe haven't quite looked at, where there could be some chance for maybe decision-making, as I'll talk about at the end? And I think it's those on the wait list. So a unique group of patients that, have undergone a lot of testing, where a lot of things like contraindications have been sort of teased out or addressed. In this population that's highly selected, are we still seeing that similar type of signal for frailty? And then what does that actually mean? So how does frailty affect those on the wait list? Going back to the US again, this was the biggest study that exists right now, just a little under 2,000 patients, and I'm sure it's even more. Just to simplify things, I'll just quickly say that about 18% of those on the wait list using the freed were frail, and a little over 200 did not survive to transplant. And kind of like I've said with every population, those who were frail were about twice as likely to die before getting a kidney. So even in this like highly selected population, we're still seeing that relative 2-fold increase in mortality. But we know that Canada is not the same as the US. There are differences in survival comparing Canadian patients to those in the United States. Waitlist attrition tends to be lower in Canada, and the vast majority of studies have been US-based. So that brings me to the study that we're hoping to have answered very shortly, which is an evaluation of frailty and its impact on health outcomes specific to those on the waitlist in the Canadian population. So we've just kind of completed the recruitment, and kind of our analytic phase is really undergoing right now. But this is a sort of an 8-year study meant to be shorter, but delayed because of the pandemic, which was really brutal for anybody who was trying to recruit patients in a prospective fashion. And we looked at those who were listed for transplant. We had Halifax, St. John, Hamilton, London, Montreal, and Regina as part of this cohort. And really, we didn't want to just look at one measure. So with that sort of weighted Venn diagram that I showed you earlier, we wanted to look at multiple measures. So the freed, the index, and the clinical frailty scale. Our main outcome of this study is to look at how frailty impacts not just survival, but permanent withdrawal, which I think is sort of an important question for healthcare utilization. And if we can sort of anticipate in the future, if we identify those who are more likely to be withdrawn, it might change the way we allocate resources, look at those individuals. But we have a number of secondary outcomes we're exploring as well. We did actually create a waitlist specific frailty index. If you recall, when I mentioned the FI should be created for the populations that you're studying, I put all the variables in it. There's around 37 variables up here. But, we have things in that kind of social cognitive domain, things in a functional domain, looking again at ADLs, IADLs, mobility. And then we did include some aspects of comorbidity, not an exhaustive list, but certainly some aspects of comorbidity in this index as well. So I'm going to show you a couple of preliminary results. We're not actually at the point where we have our final cohort and numbers. And this was just a portion of people that were done between 2016 and 2020. Now you see like 540 patients. Excitedly, you would think we have like 1,000 patients now, but I ended at 2020 for a particular reason because we just were on a complete pause for almost a year. So I don't know what our final number is, but it's not going to be as high as I would have liked, but nonetheless. So, remember, these are waitlisted patients. So mean age of around 54 years, 36% female, half of them on hemodialysis. And using the Freed, kind of very similar to the US results. So about 16% of this population was frail. Just to show you a couple of differences, one thing that stands out is in the time that we were doing this study, we were a little bit more, I would argue, conservative in Atlantic Canada. So not unexpectedly, the proportion of patients who were frail for us was a little lower than Hamilton and London. One thing that's changed a lot, and I'm curious how this is going to change in the newer results when they come out, is that we underwent that process of deemed consent, and we've tended to have a lot higher donor rates than we had in this particular era. And as a result, there's been a lot more pressure to list people. I don't know if you've experienced this here, but our prevalent dialysis population has dropped like considerably, which is a good thing because we've been transplanting quite a bit more. A couple of other differences. So, not shockingly, more frail in those who are more than 65. Longer dialysis vintage associated with frailty, but similar proportions for both dialysis modalities. And again, preemptive patients tended to have a less likelihood of being frail. Just again, looking at some of those other tools. So you can see with the frailty index, a little under 40% of the population was frail. A little different measure than the Freed results. And again, that right kind of tail, which we expect with this distribution. And then for the clinical frailty scale, it was about 15% using a threshold of 4. Just to dive into these measures a little bit more, what kind of underpins that Freed phenotype? It's mainly grip strength. And grip strength isn't something that you can easily visualize when you see someone, but I thought that was kind of curious. For frailty index, the mean score was around 0.22, and then the median for the CFS was around 3. And then just to sort of summarize the main findings, this is a kind of a preliminary look, so it's potentially may change. But again, we have the healthier Canadian population, lower risk of mortality, slightly different outcome looking at death or permanent waitlist withdrawal, but you're seeing a very similar point estimate. So not all of them are statistically significant, maybe sample size related, but relative hazards for either dying or being withdrawn from the waitlist sitting around 1.7 to 2. So again, that kind of twice as likely, or you're close to it anyway, to either die or get permanently removed off the waitlist, and more to come with the final results. So I think frailty is associated with poor health outcomes across kind of that whole spectrum of kidney disease with a surprisingly consistent mortality risk. And hopefully we'll get a little bit more answers from this particular waitlist population. But how is this going to actually change anything that we do? So how is all of this knowledge potentially going to inform how we approach care for our patients? And really what we're asking is, how do we use this in decision making? So for those that do kind of more focus on patient-centered research or work with patients when doing research studies, I think the first question to ask is, what do patients themselves think? And this was a survey, and I touched a little bit on it before, talking to patients about their perspectives about this syndrome of frailty. And I think there's a lot of sort of skepticism around it, especially from patients. A lot of them felt that there was sort of a psychological component to it, and some were a bit skeptical of it. But I think what is important is that patients in general were open to knowing what the risks of being frail are. This is just one quote. They should discuss risks. Everyone should be prepared. So this is important. So we have patients telling us that this knowledge might actually be important for their own care. This has recently been submitted to AJKD. This is led by Stephanie Thompson, and it's another qualitative study with an even more nuanced question looking at the perspectives of patients towards integrating frailty into their own care. So again, really, is this actually important to patients? So in this qualitative study, 91 participants, about 40 were patients or caregivers, and the rest were practitioners. And really, there were three big domains that were kind of teased out in this qualitative study. All groups, be it patients, practitioners, expressed a lot of uncertainty about what frailty really is. And in fact, many thought it was visible, so obvious, inevitable, and fixed. And it's kind of interesting, but those points weren't really any of the points that were identified in that consensus definition of frailty, this idea that it's fixed and you can just see it and know it. All of them felt that discussing frailty was of value, providing some idea of expectations about what health outcomes might ultimately be. But there are a lot of these sort of negative connotations around using the word frail when speaking to patients. And then ultimately, there's a little bit of uncertainty about whether you can really measure the entity of frailty, but there is a general desire to have actionable solutions to implement it and use those solutions to inform care. So this is a really nice visual that Stephanie put together, just kind of summarizing kind of the key qualitative domains of the study. So on the education side, educating not just patients, but practitioners that frailty is a real thing. Maybe it can inform some approaches to care. There is a number of different assessment tools that exist. On the discussion side, I'm doing a little bit better job of integrating frailty into decision-making, socializing it, focusing on some domains. And then on the management side, actually putting it into practice. So, measuring it, reviewing what those results are with patients, maybe avoiding the use of the word frailty, but focusing a little bit more on the actual domains themselves, and then thinking about how to address it. So what this sort of suggests to me is that it is important to patients, and I think that's where the next steps really are headed. So my first sort of thought is, before we do any of this, we actually have to routinely measure it. I suspect it's not happening here. Even in a place where we're very familiar with frailty, we're not actually doing it in Halifax either. So I wouldn't say that we have a formal strategy to evaluate frailty in a way that I'm laying out here, but I think that's the hope. So I would sort of suggest that at first visit, all patients should be screened and consider maybe having some sort of a test, even if it's just the most simple one. Repeat that screening at regular intervals. So transitions of care, particularly hemodialysis initiation, maybe home dialysis initiation. And then I do think considering it as part of the kidney transplant workup, if you look at the KDIGO guidelines that came out in 2024, they do suggest that we probably should be capturing this when we are actually working patients up for transplant. How does it actually get used in decision-making? Well, this was a study looking at dialysis versus non-dialysis initiation in CKD patients done out of the UK. This cohort had about 1,200 patients. All of them were above the age of 70. All of them had low GFR. And they wanted to look at what was associated with starting dialysis versus conservative care. And in this particular case, they did use the CFS, but unfortunately, they did it retrospectively. So it wasn't like the frailty scale was actually known to the patient in that metric that I showed you before. But when looked at retrospectively, a couple of things. One is you can kind of see in general, a lot of older adults do get directed towards conservative management. So that kind of purple bars here. And even though, it might have been sort of a blinded sort of measure that was put on, you can see that there was not blinded to the patient, but perhaps to the ultimate outcomes. You can see that CFS per unit increase was associated with a lower odds of a dialysis initiation. So a tendency to frail patients being directed more towards conservative care. But again, how do you glean anything about its role in decision-making if it's applied retrospectively? So we tried to do this at our institute. We actually developed a nurse practitioner-led clinic in 2019 with a focus on decision-making for frail patients. So ultimately what we were trying to do is when you as a physician saw a patient who you thought might be frail, you directed them to the nurse practitioner They did a clinical frailty scale, but a little bit more of an informed one using some aspects of a subjective, of a geriatric assessment as well. And then in speaking to that patient, directed them to various options. So non-dialysis care, addressing care goals, decision-making, and potentially referring to geriatric medicine if they thought that that might be the right thing to do. When we started this clinic, we had about 61 referrals fairly quickly over about a year period. 48 of them were fully evaluated. About 32 of those had decisional conflicts, so they didn't really know what they wanted. Did they want dialysis? Did they want conservative care? They were sort of struggling with that modality decision. And ultimately, 14 of them did choose conservative care. So a bit of a, an early signal to suggest, okay, well, maybe this is a sort of a frailty-informed approach to care where you might direct patients towards the non-dialysis option. But these dates are perhaps, how they are for a reason. And something happened in 2020, and that clinic completely shut down. And then that nurse practitioner is no longer doing it. So while we had maybe the start of something, we were unable to sustain it. But there's maybe some interest in bringing it back. So what about transplant? So I highlighted the waitlist for a reason. Is there any idea of how frailty might be used for decision-making in transplant? So this was a US study that was done that showed that centers that always assess frailty for the waitlist tend to have lower rates of transplantation, but also have a lower risk of death before transplant and about a 30% improvement in graft survival. I don't know if that's actually a good thing or not. Do we really want to sort of advocate for lower rates of transplant? But certainly the signal is there. So then the big question, though, is, okay, if you were working somebody up and you found out that they are frail, should you actually transplant them? So when we generally think about contraindications to transplant, we usually think about conditions where the risk of transplant might be too high, both with surgery or maybe immunosuppression, and the chance from benefit from transplant might be too low. And knowing that we have, a scarce resource, we maybe reallocate that resource to somebody else who might actually benefit instead of this particular individual. A long time ago with Bryce, we looked at, contraindications that we all know. So dementia, multisystem disease, and active cancer. And, Bryce looked at the probability of actually benefiting from transplant using some modeling and found that, by and large, with established contraindications, the probability of benefit is, less than 20%, some cases even less than 10%. Kind of reiterating that contraindications that we think about are in fact not associated with, a probability of success after transplant. And if you were to actually look at this entity of severe frailty, it would fall into a similar range as any of these conditions. So that might make you think, okay, well, maybe if someone's, graded frailty scale score or something is high enough, it should be a reason why we don't actually transplant them or don't actually list them. But the caveat to that is that frailty does change after transplant. So there's very few studies, I would say there's hardly any actually in our population, that have looked at whether you can modify or improve frailty. But the one exception is transplant. And transplant is this sort of natural experiment where you restore a lot of biology, some of all those processes that I showed you, inflammation, the rate of telomere attrition, all those things might actually slow down when someone gets an organ. And sure enough, if you look at frailty at the time of transplant, so this is the proportion of people who are frail, about a month after transplant, that proportion does tend to go up. I think this fits with kind of that early operative risk that we all know. By about 2 months, it's on the downswing again. And by about 3 months, it's actually lower. So transplant is this sort of restorative treatment. Wouldn't be the same probably for something like dementia or, metastatic cancer. So that's the big difference between frailty, which might have that very high risk, and some of those other conditions. So what might be more important is this notion of dynamic frailty. And this is, again, something that I think we'll get a little bit more information about with our waitlist study. So perhaps how frailty changes in that time over the waitlist is of more value. This is looking at patients who had a frailty evaluation done at the time of their kind of workup and then at the time of transplant. And just really quickly, those who got worse over that time period, had a subsequent higher mortality hazard in post-transplant state. Those who kind of got less frail, irrespective of what they started at, tended to have a lower risk. And those who were stable was the reference group in this case. So it does look like dynamic frailty may actually have an impact. But that still doesn't kind of answer what the big question is there a tipping point? Like, is this kind of our newest contraindication or not? We're trying to look at this right now. It's not easy with the data that we have, but what we're trying to look at is over about a sort of 11-year period or so. Individuals who are not referred, who did not have a contraindication to transplant, and what their frailty score was. So these are people who started on dialysis, were not referred, didn't have an obvious contraindication, and we base that on a detailed chart review, 2 individuals with a third for consensus. The thing that stands out here, if you look at people with kind of those frailty scale scores of 4 to 5, about, let's see if I have it here, about, a large proportion of them either were withdrawn or died. So these are patients with no contraindications, and about 30% of them ultimately did develop a contraindication. Looking at those with scores of 6 to 8, those proportions are quite a bit higher. So it does look like this risk of development of a permanent contraindication is pretty high in this population. But what's interesting is a lot of those contraindications are usually cardiac or malignancy. One could argue that a malignancy a contraindication may not be one that's accelerated by dialysis initiation, but I would argue that a cardiac one might be. So how can we actually use this information? My view is not to use it as a way of identifying, a contraindication, but of prioritizing things in a slightly different way. And this is, I think, where the next kind of phase of research is going to be. So in the conversation that I was just mentioning right now, maybe we should instead be looking at prioritizing organ allocation for pre-frail and frail patients, as opposed to treating that as a contraindication through things like preemptive transplantation or targeted allocation. We do probably have a knowledge gap in frailty and approaches to dialysis delivery. There is research being done right now that is led by Annie-Claire Neto-Fredette, looking at frailty and modality transitions. So how does it actually inform how people move modalities? And then last but not least, I think where everybody would be really excited is, you've pointed out this condition. Can we do anything about it? Can we make it better? The short answer in our population is not yet. There has not really been a strong study outside of some with the focus being exercise more than anything that has shown a reversibility of frailty beyond transplant in this patient population. But there are a lot of upcoming trials that might help to sort of identify if this is an entity that can be fixed. So that's all I have for you today. So, frailty is highly prevalent. You can measure it in a lot of different ways, associated with poor health outcomes. We're starting to see how it can maybe be used in decision-making, but we're not quite there yet. And I think if I could sort of predict what the next 10 years are going to be, it's mainly going to be focused on interventions to support patients who are frail, and then potentially interventions to address or reverse frailty severity. And these are the important people in my life. Maybe not so much this guy sometimes, but happy to take any questions. Thank you very much.
Thanks, Karthik. That was a really great overview of the topic. If people online have questions, please raise your hand. I'm sure there'll be many questions in the conference room. But I'll start off with the, you showed the frailty measures right in the beginning. And yeah. I would like to do that in clinical practice, right? We have a lot of patients who are in hypertension. It's a common problem that people say, oh, they look frail, and let's not do intensive BP lowering. And it's like, really, that's not right. You should be formally assessing this. So if we had to do this in the routine clinical practice, I'm assuming the CFS, the clinical frailty scale, would be the one to use. How easy, how hard, how much time does it take? And how would you say we should do this? I don't have a nurse practitioner clinic either.
Yeah. So the CFS, like, if you look at it, you can just kind of look at the page, read the categories, look at your patient, and assign them to one of the categories. Very easy. The issue is that actually the right way to do it or not? I think any use of this tool in the literature, that's what people are probably doing. They're like, they look like they're about a 5, and the pictorials are helpful. It's better than your kind of clinician impression where you're just like like kind of not even having something to guide you. But I would say as a screening tool, that's an easy way to do it. And by and large, like it's going to predict or associate with badness. That would be the impression I would get. If you had a little bit more resource at hand, you know, and you were able to take that approach, but maybe complement it with some functional measures. So, you know, like a grip strength measure is not really that hard to have. There's probably a way to do it. If you're measuring blood pressure, maybe there's a way to do that as well. And like a walk time kind of measure is probably not that hard too. So if you could couple something like the Frailty scale, which is your impression, with some sort of an objective tool, I think that would be ideal. When I talk to people that do this, like in the US especially, they seem to think that it's very easy to do all of that. And they're always wondering like, why are you saying that it's so hard to do these like physical assessment tools? But I don't know, maybe their clinics are different than mine. I do find it's hard. There's like 1,000 patients running around. It's hard to put these into your workflow. But, you know, knowing that it has sort of the ability to maybe start to inform things that we do, where traditionally we would just use numerical age as our tool. Oh, this person's very old, therefore I'm gonna, you know, maybe not immunosuppress them, or I'm not gonna do this. But like, is that chronological age all that valuable? Maybe not. So if you know that it's important and it has this association, I think incorporating kind of those two measures to me would be the best approach.
Sounds good. Are there other questions from there's nothing from the online audience yet, and you can stop sharing so you can see who else is there.
Sure.
Is there are there any questions from the conference room? Yeah, Mark.
Thanks, Karthik. That was really great. Like I dabbled a little bit with this years ago and then got frustrated by the fact that you could essentially take a tool and go like, well, we didn't have like that test, so we just did this, and that's kind of the same. And then another group comes along and says, well, I didn't have the resource to do the timed up and go test, so just asked the guy whether he could get out of a chair without using his arms, and that's kind of the same thing. You get this kind of bio creep with the test. So it worries me a little bit that we might make decisions about transplantation in particular based on a bunch of tests that seem to have a major reproducibility problem.
Yeah. So I agree, and I showed you that reproducibility problem is one. So everything you're saying is correct. When you look at the original Freed, I don't know if there is, with the exception of maybe one group, there isn't a person who's doing the original Freed as it was developed. And they're doing exactly what you say. So they're taking the Minnesota Leisure Questionnaire, which is a 20-minute deep dive into physical activity. It's more of a questionnaire than I've ever seen around physical activity before. And then they're not using grip strength. They're using the answer to like, SF36 or something. Like they're substituting things. So I totally agree with you. I don't like that aspect of the creep. The other thing I don't like is that we don't actually do reliability testing properly with any of these, tools or measures. I don't even know if the original derivation of the Freed, there was a lot of robust reliability testing that was done. But I mean, if you PubMed Freed and anything right now, there's probably thousands of studies that are using some iteration of it. So I agree. I think we have to be cautious. I think if I were to take the study that we're doing, and this is partly why I think it may be informative, is we're trying our best to sort of stay true to what they did in the original study. But even we have been forced to pivot. Our main reason for having to pivot was like pandemic related, where we maybe couldn't get in and do some of the things that we normally could have. But we have the opportunity to actually study it a little bit better. I think that where I'd like to sort of see a bit more focus moving forward is like test, retest, inter-rater reliability, some of these things that you can see there's like a big deficiency in, just to get people a little bit more comfortable with the fact that what they're seeing and measuring and assessing is the right thing. And maybe something like this mathematical FI might overcome it. I mean, when you have 35 to 40 deficits in a condition, some of which are like, maybe a little bit nuanced or subjective, can get a little bit washed out at least. So maybe you won't have as much of that lack of reproducibility, but even still, it's lacking in that tool as well. So I agree. I do think, though, that the waitlist is a tricky population because even established kind of contraindications, there's a little subjectivity there too. I'm not sure how you do the waitlist evaluation here, but if I were to take our approach in Halifax, we have a committee that sits together and hears everything. And someone has like a cardiac contraindication, but is it really a cardiac contraindication? There's a long discussion about it. Someone might have a vascular disease contraindication, and then you go to the vascular surgeons and they'll tell you like, I could put a kidney in anyone, if I'm the person that's operating. So I don't know why you want my opinion on this. I don't know if you guys get that. I get it all the time, but it's so there is a little bit of nuance around the waitlist too. And I think we have to ask ourselves what we want to really do with the information. I think that's the most important question. If you see someone and it's, you really worry that they're not going to get that organ, does that mean that you should say, okay, let's stick with our process. Let's evaluate everybody. Anyone with a score of 6, we're not going to list them. Or does it actually mean, why are we letting people get to scores of 6 on our wait list? What approaches can we do, strategies can we do to, mitigate that or expose them to, the opportunity to get an organ a little bit earlier to improve their health outcomes? That's like the exact opposite view. But I think that's kind of where I hope this literature will sort of head.
Yeah, thanks, Karthik. I think there's a question online, Dr. Power. Yes.
Sorry. Yeah, I really enjoyed your presentation. It's very interesting. A couple of points and then a question. As you know, there's lots of studies on frailty being done in patients with going for TAVIs. And you may be aware that Dan McIsaac, who's an anesthetist in Ottawa, is doing quite a few national studies on prehab prior to going to various surgeries. Some of the surgeries he's looking at are orthopedic, and some are minimally invasive colorectal surgery, where they're doing using the free frailty index, but they're trying to do a prehab program with nutritional support and exercise to see if that will help change outcomes in patients who have high frailty indexes. My question to you is twofold. One, as you said, how are your scores really being used? Because I have certainly found seeing patients who are going for TAVIs who tend to have high frailty scores. How do you use the information when you start talking to patients and families? Because to tell you the truth, it's easier for me just to say, yeah, they're really frail, go for the surgery. Because canceling surgery or canceling potentially a renal transplant is going to, I assume, be a long and big detailed discussion. And sometimes it's easier for us as physicians just to turn the other direction. So I'm just wondering, one, how are you really using this information? Are you having some kind of support group like social workers that can facilitate some of that discussion? That's one question. And two, do you think there is a point where you cannot on frail people? And my clinical experience with the TAVI patients is there is a point whereby even though you give them a TAVI and similar to a renal transplant where you think you're going to, I don't know, I'm not a nephrologist, improve flow, improve outcomes, that there is this kind of point whereby you can't on frail, even though you've given them a transplant.
Yeah, so so your point about prehab first, just to talk about that, I think is an excellent one. I didn't show you the literature on prehab in the kidney transplant population, where I think it would by and large happen on the wait list, mainly because there's just not a lot of data out there yet. There's one study where they showed that with prehab there was maybe a sort of tendency to reverse frailty, but the numbers were very small, not enough to really put a lot of weight behind it. But I think that's kind of where there is a lot of interest. I will say that if frailty is multidimensional, sometimes we, that sort of square peg round hole. So if you have a multi-domained influenced entity, and let's say nutrition, for instance, is the most, the biggest domain that's affected in frailty, maybe a physical activity intervention is not the right one. So a lot of these trials that are coming through are multimodal, trying to identify, well, what aspect of frailty domain is impacted that can be fixed or addressed. And I think that's kind of where the direction is going to go with some of these multimodal ones. Do we use frailty in decision-making? For us, we don't yet. I think that's actually a big part of this study, and the value certainly for us is once I kind of can put this information together, are we going to start actually properly collecting these frailty measures in our waitlist population and trying to use it to inform care? I agree with you. Like, I don't think there is a scenario where without another compelling reason on the day of transplant, if someone had a frailty measure done, that I would cancel a transplant. And in fact, I would almost argue that a frailty measure at time of transplant is kind of too late, because you really have lost your window to optimize them. If that does become something in the future, you've lost your opportunity to use it as part of your decision making. It's kind of like just that last minute. I think that would be, I'd probably get my knuckles wrapped for that. But I do think that having some sort of graded measure of it on the wait list might allow us to look at, okay, well, maybe this person is progressing and getting worse. If there is a threshold where it's gone too far, now I can have a conversation with them to say, you can appreciate that these things are causing you problem. I think maybe we need to take you off the list. And I feel like that's where there's a little bit more value add, but what that would require is regular measurement. We often do this thing where we'll say that, okay, list them, but they're an old blood group. We know it's going to be a long waiting time. So they need like a very close eye, because I think they're going to get worse as time goes on. So there may be a value in doing it regularly so you can catch it before it gets to the point that you're the day of transplant and you're going to, make a decision that may not be the right one. And it's hard too, because, somebody who is very frail, they get the organ, who knows, maybe they have a dramatic turnaround. But to your point, I actually do think there's probably it's too late point. We just haven't quite found out exactly what that is, but.
Thank you. And I think we're just over time, so we'll call it for today. Karthik is around if you have more questions, especially if you are at Riverside, to bug him. And this definitely looks like something that's a research in progress, and I'm hoping this will really impact what we do in the future. Thanks, Karthik.
Thanks a lot, Swanson.